from Honolulu, Hawaii, and today Brandi and I are going to be doing a tummy tuck.
Hi, I'm Brandi. I'm a certified surgical tech, and I work here with Larry.
Today, we'd like to tell you about what we're going to do kind of step by step to help you understand. So, first, we mark the patient, which we've already done in the recovery room, and we mark a midline. Plastic surgeons always like to mark a midline.
Oh, yeah.
Makes them feel better.
Yeah, better about their lives.
Yeah. And then after we do that, we mark where we're going to make our incision. Now, this young lady has an interesting configuration to her abdomen. She's lost 125 pounds. She's also a mother. And so it's both post-pregnancy and post-weight loss. What we're going to do is the lowest line we mark is 2 finger breadths above the vagina, because that's where we'd like to get to. And the reason for that is it pulls up the vulva very well, which of course puts the kink back in the urethra, so women as they get older don't have stress incontinence. The other thing that is kind of guaranteed with this surgery is by sewing the muscles together, repair the muscle separation, which will then clear up low back pain. What's going on is the muscles of the back are working overtime because there's no compensatory muscles in front to balance them out. We inject xylocaine with epinephrine up and down the abdominal wall, and then we do an incision around the umbilicus, because we're going to pull all the skin down, and we're going to find a new home for what is now the top of the umbilicus, and we're going to then bring the umbilicus and up through the suture line towards the end of the surgery. And later we're going to anchor it to the abdominal wall. Then the next thing we're going to do is to dissect above the rectus sheath, above the covering of the muscle, we're not there to clean off the muscle, because if you clean off the muscle, you're going to get a rip-roaring seroma, because you're interrupting all the lymphatics. So we leave a little bit of stuff on top of the lymphatics. And here in Hawaii, we like to call that stuff Guri, which is really good ice cream from Maui, or sherbet, or something like that.
I think it's more of a sherbet.
More of a sherbet, yeah. And so that's our term, Guri. We leave a lot of fat and some subcutaneous tissue on the rectus sheath, on the muscle covering, in order to leave the lymphatics intact so it can suck up any fluid post-surgery. Next, we dissect all the way to the bottom of the sternum. That's known as the xiphisternum. And now we've got a complete picture of what the abdominal wall looks like. The next thing we do is to repair the rectus diastasis, the separation of the muscles. And we do that with, what kind of thread do we use?
S. Jackson.
S. Jackson, that's a braided polyester.
Indeed it is.
And?
V-lock.
V-lock. And V-lock is a monofilament nylon with little V's in it, or little arrows in it, so that you can sew in, but you can't pull it out. So if anything should rip apart, it only rips at one segment. It doesn't rip all the way down. So we've got 2 layers of permanent suture to repair the rectus sheath. Then once we've done that, we anchor the belly button to the abdominal wall, so that the skin can come down to the belly button, as opposed to the belly button coming up to the skin. And we anchor it with
2-OPDS.
2-OPDS, so that we can be sure that it will stay down until scar tissue replaces it. And then we also anchor it at 3 o'clock, 9 o'clock, and 12 o'clock, but not 6 o'clock, right?
Not 6 o'clock.
Not 6 o'clock. And the reason for that is, if you do a really tight repair, as we plan on doing, then if you have